These are the learning objectives of today, tomorrow, and day after tomorrow. Just quickly go through. We've introduced lung zones, and maybe, if time permits, introduce V over Q. Tomorrow we'll look at details of V over Q and their clinical implications, and at the end we'll look at physiological dead space and this thing called shunt. Is like this, isn't it? This is the ground floor, the first floor, ground, first, second. I said that the water pump should be around here, P for pump, right? If you were to switch on this pump, let's switch it on. Plus is you've turned it on. The pipe of this pump will bring water to this area with ease. What about the ground floor? More ease because of gravity. It will literally drop. The water will just drop to the ground floor. No problems here because the gravity will assist it. What about this area here? Well, the problem was actually the area above the level of the pump. That's why you got the pump. We install water pumps in houses to get water to the upper areas of the house. The ground areas and basements don't have much of a problem. So this flow from this point upwards, this is where the effort will come. Yes, because it is anti-gravity. It's going against gravity. Yes? Okay. Very similar situation happens in the lungs and the heart. Okay? If this is the lung, let me just make one lobe. This is the heart. Somewhere around here. This is the pulmonary vessel entering through the hilum of the lung. Hilum of the lung roughly is in the, again, I'm not going for anatomical detail here, but hilum is somewhere around this area, the middle. So you can imagine it's a very similar situation. The vessel entering here, lower areas of the lung will have very little or zero problems with blood flow. With Q, no big issue, no problem at all actually. In fact, if I may say that blood flow is a lot in the lower areas of the lung, from now on called the base of the lung, as compared to the apex of the lung or apical areas, I would be accurate. More blood flow is at the bottom than at the top. I made it small because there is less blood flow naturally on the top areas, and in the middle it's okay, it's normal, all right. A lot, all right, less. Questions? This is simply the effect of gravity. Okay. Blood is a complex liquid, isn't it? It's actually a tissue. But just to compare it with the air, it's a liquid. It behaves like this. Effect of gravity on blood is such that we have different areas of the lung according to Q. We call them lung zones. So lung is not one homogeneous structure when it comes to blood flow. Because of the effect of gravity in the upright individual, there will always be blood tending to favor the area lower than the entry of the blood vessels, the base area. At the level of the heart, there will be all right blood. Okay. However, as you climb upstairs, there will be less of perfusion as compared to the lower areas. ये बात ठीक है? Is this okay? Would air also have a similar distribution? It does. And I always find this misconception in every first year. That's why I mentioned liquid. What is the difference between liquid and gases? The molecules are just spread wider in gases. You can make a gas from water, can't you? And then condenses back to liquid, then evaporate it into vapor, then condense it back to liquid. So what's the difference? It's two different states of water, isn't it? It's just that the molecules in gases are spread apart, more apart than they are in liquid, right? So the effect of gravity on liquid is more profound than it is on gas. However, gases also get affected by gravity, right? So we are giving air into this lung as well. It's not just blood. We are giving it air all the time through the trachea. And that also enters around the same point, the hilum. So this is the entry point for the airways as well. So now just make the concept right here so that our job becomes easy later on. That air also tends to favor the, via effect of gravity, the lower areas, then the middle, and less on the upper area. However, this effect is much, much, much less as compared to liquid or blood. Okay, technically correct. So if I may summarize, maybe the last point for today. However, the very, very key point now, the summary of the whole thing. If I were to divide the lung, and please note this very, very clearly now. If I were to divide these zones that we have described today into roughly 3 areas, the basal areas, the one at the level of the heart, and the areas above the level of the heart. Roughly those areas. Remember, there is no, it's not a geographical thing or an anatomical landmark. It's a physiological concept. These things don't exist as physical landmarks. There is no marking on your lung that this is the start of this area of that. It's just concept here. So you throw in liquid and you throw in air, and then gravity and the pressure exerted by the heart does the rest. If I say that perfusion and ventilation is more, both are more at the basal level of the lungs as compared to the apical regions. Is this something that you would agree with? I'll say it again, because tomorrow I'll be moving from this point onwards. I won't explain the whole thing. So ask me a question today. Both perfusion and ventilation tend to be more here than here, and certainly than here. So said it another way, as you go from base to apex, as you go from the lower areas of the lung towards the higher areas of the lung, say you're trekking up, perfusion and ventilation both decrease. ठीक है? अभी हम डिवाइड नहीं कर रहे ना, अभी हम डिवाइड कल करेंगे. अभी हम सिर्फ ये देख रहे हैं कि अगर if you take ventilation separately and blood flow separately and just trek from bottom to up, what would you find, say, in ventilation? In case of ventilation, if lung was only pumped with air and then you are allowed to go from base to apex, what would you find? Only ventilation. In the standing up individual, there will be slightly more ventilation down. As you go up, it will slightly decrease. Because again, gravity affects air. Please get this clear in your head. It does affect air, but to a very little extent as compared to liquids and as compared to solids. Solid pe काफी effect है, because its all molecules are compact and the effect of gravity is very direct as compared to if I were to pour water. Okay? Again, if there was no friction, etc., the feather and the block of steel would drop at the same rate. But this is not a physics class. Now, if you're absolutely certain about the following conclusion, that as you go from base to apex, beta, there is a reason I'm repeating this. The whole building of V over Q stands on your understanding of what I'm saying and repeating. When you go from base to apex, blood flow decreases. This is an obvious point. Just agree with me that this also affects ventilation. Just agree. It happens. It is like, it's right there. They did not emphasize effect of gravity on gases in your physics class earlier. They should have. But it happens like this. It's much less than liquids. Now, as I already said, the effect of gravity on liquids is much more than gas. So this change will be more profound in the basal areas of the lung for liquid than apex gas. There will be much more Q at the base than V. I'll rewind. I'm available today for all the basic questions, not tomorrow. Tomorrow I'll assume that you know this stuff. And of course you will have this video. But I'm here live to explain it to you. First, let's revise. When you compare both of them together, let's lump them together. Q and V are brothers. They reside here. They have a lot of clones. There's a lot of V and Q at the basal areas as compared to the apical area. Something that I think, mentioned 10 times now. Okay? This is okay. Now you do one other analysis, a bit more complex. Can we compare them individually, not as a combo? Can we compare, okay, if I were to compare V with Q here, and then V with Q here, is there a difference between the patterns of their distribution?
Yes. Yes.
Big time. Because gravity tends to affect fluids more than air, something that you're stuck on, right? Now let's use your confusion to explain something. The Q's at the bottom of the lung will be much higher than the V's. Now we are talking about the region. The Q's here will be much higher than the V's. And here, the V's will be much higher than the Q's.
Gravity acts less on the air.
Yes, it does. Something that you now are clear about. It's like you are looking at, subhanAllah, some people are actually talking during this particular lecture. It's amazing how stupidity works. Where was I? It's like looking at two things, the same thing from different angles. One angle is looking at them together, then comparing this togetherness with this togetherness, and you see a pattern. Then when you're satisfied with this, then you say, okay, but these are two different things, isn't it? Yes, they are two different things. So let's separate them out. Let's pull them apart and compare them together and then move to the apical regions. So when you do that, what you see is as you go along from to here, Q drops more than V. Final point. If I were to derive an equation here and here, this is where the V over Q comes. It should clarify things better. Absolute clarification will come in tomorrow's lecture, which inshallah should start on time because we are short on time. If you were to calculate V over Q here, what would you get? First, just appreciate the question. Keeping all the gravity influences on blood and ventilation together, now just work out if there is a ratio calculated, because this ratio will tell you how they are behaving together, won't it? This is where the money is. This is where the question is. So if V over Q is calculated at the base of the lung, and then V over Q is calculated at the apex of the lung, how would it be different? I say it may be the case. Please remember this may be. I will tomorrow clarify this maybe. But maybe it approaches zero somewhere at the most basic basal level of the base of the lung. So the lung is actually like this. So if this is the base, it's not, a bit like this. So if this is the entire base, this area is the base of the base, if I may say so. It's really the lowest terrene part of the lung. Of the entire base, this corner here is the base, the most lower part of the base. Get it? So maybe right here, the V over Q may approach zero. How can it approach zero? Yes, because this is the area where the gravity is blindingly too much. This is the point closest to the floor, isn't it? As compared to this point, which is farthest away from the floor or from gravity point of view. So the gravity would be really harsh here. So the Q will be too much as compared to V. It will always decrease the value of the ratio. It's mathematics. Now, what is this sign? Infinity. Why is it infinity over here? Because again, gravity impedes, retards blood flow. So you will normally have in these areas, you will normally have less blood flow as compared to airflow. So V over Q will always be towards the higher side during the in the apical upper areas of the lung. Yes. However, there may be a situation that the most apex, really small apex, topmost notch, dot, whatever, of the lung may have a situation where This is almost 0. So anything divided by 0 is infinity. This is mathematics only. Okay? Not infinity as in La Mahdud. La Mahdud is only Banza. But infinity here is just to tell you that you call it denominator, right? That the denominator is really less than the numerator, the one on top. Okay? So with this, we conclude today's lecture, but please. Lung zones and V over Q ratios yesterday. We will start from where we left. These are the learning objectives. So we'll be looking a bit more closely at lung zones today. We look at V over Q, how it is made, and we look at the clinical implications of what this all means in real life. Remember this very small, simple flow chart or flow of concepts or connection of concepts. So due to uneven distribution of blood and air throughout the lung as you go from base to apex or however you want to go, as described yesterday, this uneven distribution has implications. It has consequences for what? Eventually, for what the lung is most famous in doing, gas exchange. So you don't have, as I yesterday explained, lung is not a homogeneous thing, an organ, when it comes to blood flow and air flow. Okay, it differs from area to area. These areas are called lung zones, which give rise to different V over Qs throughout the lung, and these various V over Qs lead to differences in gas exchange. So in one line, expect a bit different blood gas exchange wise or blood gases wise coming from the apical region of the lung as compared to the base region of the lung. I will let that settle down a bit. I have told you something very radical today. What I've told you is that when blood comes out, so let's say you put in a glass of blood inside the lung, theoretically. So from that glass, most of the blood would go to the basal areas, towards the base. Some of it will stick to the level of where you threw the glass in, and little will go towards the apical areas of the lung, effect of gravity. Similarly, the air also follows these three regions or zones. Now, when you collect that liquid that you threw in the glass of water or whatever back to check what is happening to this fluid, you shouldn't be surprised that the fluid collected from the base of the lung is different, quite different from that collected from the apical regions of the lung. There are differences. Is there a difference in the liquid itself? No, it's the same liquid. It's the gas content, the oxygen content, the carbon dioxide content of this fluid coming from apex and coming from base. The difference is in blood gases. Any ideas why would there be differences in the blood gases in the fluid? The answer is should be pretty obvious for the ones who were listening yesterday. There is a V over Q peculiarity in the apical regions and a different V over Q setting in the base of the lung. That's why blood gases reflect where they are coming from. The blood has a signature. So the blood returning from the apical regions has a signature where when you look at the blood gases, you can tell where is it coming from. Okay? Theoretically speaking. Why do I say theoretically speaking? Because when blood is collected in the left atrium, it doesn't really matter where it came from. It just mixes, everything mixes when it hits the left atrium. These differences are theoretical in the sense that in the intact human being, this is a physiological observation that the pulmonary veins draining the upper areas of the lung would have a certain composition of blood gases different from the pulmonary veins which are collecting blood from the basal regions of the lung. Okay, when they combine and drain into the left atrium, it's all the same. But of course, This is exaggerated. This becomes very important clinically when there is a problem in the lung. That's when you want to dissect this whole concept out. Normally, it doesn't really matter. Why doesn't it matter in normal people, and why it matters in certain disorders, that we'll do today, inshallah. I deviate significantly now from the way Guyton has presented concepts. This is my own recipe. Okay, I teach lung zones along with VQ and along with blood gases, because generally all of these are connected. Lung zones, V over Q, and blood gases are connected concepts. However, they are given in 2-3 places in Guyton. So what I've done is I've taken them out and connected them. Okay, and you will be tested also, not just in first year. Eventually, in higher exams, they are more interested to know if you know what is the effect of all of this business on blood gases. So it's reasonable to teach you right from the start along those lines. So we know that gravity affects blood flow. We know that gravity affects air as well inside the lung. We've done that yesterday. This is an anatomical bit here, that when you go from apex to base in the upright posture, the effect of gravity is such that blood flow and ventilation both decrease as you go against gravity, something that I demonstrated yesterday. However, there are different postures. You are not always standing. Okay. So in the recumbent posture, i.e., when a person is lying flat but at an angle, like patients in the room in a hospital or in a ward, that's called the recumbent position. The flow is more in posterior than anterior, because the guy is like this. Okay. And if he's supine, he's lying flat, then the whole thing equalizes because the effect of gravity averages out. Everything is the same when you lie horizontal. So when the lungs are horizontal to the floor, everything is the same way. Okay. So this is the effect of posture, underlining the fact that the blood is the pressure that blood exerts is a hydrostatic pressure. Okay. From your understanding of physics, you know what a hydrostatic pressure is. Hydrostatic pressure is by virtue of its. Now, this is the main crux of the matter here, right here. And this is a diagram of Guyton. Okay. So Guyton describes lung zones strictly on the basis of changes in blood flow. And hence, here I am telling you the same. Okay. Different books may present us different version of this. Again, if you stray from Guyton, look at some other books, the whole thing, zones, VQ, blood gases, is usually discussed in the same go. The more clinically oriented physiology books. Okay. However, that is a basic textbook for undergraduates. So it basically breaks it down into easy to understand components, which is fine. So here in this chapter, he only discusses lung zones, not the implications on VQ, and certainly not the implications on blood gases. So what does he say? Well, he says that blood zones, strictly speaking, are based on the differences of blood flow, like we described yesterday. No mention of ventilation as such. Okay. So when we are talking about blood flow, where does the blood come from in the lung? The heart. So it's natural to think about, okay, how does the heart pump blood into the lungs? So you have to go to cardiac output. Very simply, what he has demonstrated in this diagram here, for the upper diagram, the middle, and the third, I will come to the zones in a bit. Observe what's going on. He has made an artery. PPC is capillary pressure. So an average pressure which keeps the capillary patent or open. He has not gone into details of this. So if you are considering upper areas of the lung where there is difficulty for blood to go anyway, it may never be the case that blood pressure defeats alveolar pressure. Alveolar pressure, said in another way, alveolar pressure or ventilation pressure will always supersede blood pressure. We did it yesterday. This is old stuff. In upper areas, let me say it in that language. In upper areas, V is always higher than Q. That's what I'm saying. He does not introduce V over Q in this section of the chapter. That's why I'm sticking to his language. So blood flow is always less in the upper areas as compared to the air that the alveoli of this region are receiving. So if you lock down to the alveolus model, you just visualize an alveolus and the surrounding capillary that is bringing blood to it. You should always imagine this scenario right here, the top. So big bulky alveolus pressing down on the low pressure alveolar vessel. This is why we showed you this diagram. So in this area, which is the topmost area of the lung, the artery, the vessel that surrounds the alveolus is always under pressure. So low flow, more air. Remember this, please. More air, less blood. It has implications. Number two, what about areas which are at the level of the heart? What would happen there? Well, when the heart goes into systole, the alveolar vessel would open up properly and beat or defeat the alveolar pressure. So this is where the alveolar pressure and alveolar capillary pressure equates. It's the same during cardiac systole when the push comes and it's at the level of the heart. So alveolar vessels would nicely open up and bathe in the alveolar air gases. And what happens during diastole? Diastole is when the heart relaxes. When the heart relaxes, the push drops and hence the capillary sort of gives in to the alveolar push, alveolar pressure. This happens in the middle zones, which he says is lung zone 2. In lung zone 3, I've skipped saying lung zone 1. There's a reason for it. We'll come back to it. Lung zone 3 is where the basal areas of the lung are. Yes? And in here, we know that gravity really comes to the rescue of blood more than it comes to the rescue of air because of the weight. So in here, it does not matter if the heart is in systole or diastole, blood flow is always more than alveolar pressure. So blood pressure in the alveoli will always be more than alveolar air pressure at all times, irrespective of cardiac cycle. What's happening over there is irrelevant. So I'm quickly recapping from base to apex. In basal areas, lower areas of the lung, during the entire cardiac cycle, basically the pressure inside the alveolar vessels is more than alveolar air pressure, ventilation. In the middle areas, it depends. During systole, the vessel pressure is more and it equates with the alveolar pressure. However, in diastole, the pressure within the vessel drops and the alveolar pressure compresses it. In higher areas, it's the reverse. The blood pressure never beats the alveolar pressure. Ventilation is always higher than perfusion. Okay? Any questions? I've described to you lung zones now. That's it. I will now go higher and more complicated. What are its implications, and then eventually what are the clinical implications? So if you have a question, fire away now or hold your peace. G. Coming to that. I'll come to that. Any other questions? So first question was, why did I skip zone 1? I'll answer it straight away. And number 2, the bit about exercise, which I will answer now. Okay. So assuming that you are with this program, you have understood what are the differences in blood flow, i.e. perfusion, and alveolar pressure, i.e. ventilation, in higher, middle, and basal lung areas, assuming that you have some understanding of this. When Guyton says lung zone 1, what he means is an abnormal patch of lung tissue in the highest area of the lungs, which almost does not receive blood flow. It only receives air. It's very high up, and this is abnormal. Please make a very strong mental note of this. Lung zone 1 of Guyton does not exist in normal human beings. Of course, there are profile of COPD. I'm saying COPD so that you can have a mental tag to your memory that lung zone 1 does not exist in normal human beings. There cannot be a situation where an alveolus anywhere in the lung, irrespective of gravity or space or whatever, that it does not receive any blood at all, and it only receives air. This is no, not allowed, and it shouldn't have. That's why I skipped saying lung zone 1 because it needs a separate explanation. Are we okay with that? Coming to the second point. In a normal human being at rest, like yourself, there is only two lung zones, should be only two lung zones in the lung. Lung zone 2 and lung zone 3. These can be nice little MCQs. Normal, resting human being, upright, 2 and 3 lung zones. That's it. One should never, in any posture, one should not exist. Once you exercise, you start exercising, the lung becomes lung zone 3. How? Well, ideas? Because the pumping of the heart has increased. Not just increased in individual contraction, but the number of contraction has also increased. So that means more blood is being pushed into the lung at unit time as compared to rest. So what does that mean? That means that it does not matter where you are in the lung, it will get continuous blood flow throughout the cardiac cycle. What is that zone? Zone 3. So in exercise, the entire lung becomes zone 3 of a good, healthy individual, optimized for maximum gas exchange of more blood as much as this guy can do exercise of. Okay? Now, here I introduce V over Q and blood gases. So I mentioned yesterday that as you go from base to apex or however you do it, there is an increase in Q and there is an increase in ventilation. I said it yesterday. But how much? We said that if you go from bottom to up, the drop in Q is much more than the drop in ventilation. And we discussed a bit of physics of that, the whole thing. Okay. So there is a 5-fold drop in perfusion, blood flow, as you go from base to apex. There is only a 2-fold drop in ventilation. Both drop. However, the drop is not symmetrical because one is a liquid, complex liquid actually, and the other is a gas, is air. So if you want to calculate V over Q for base areas, not base as in one. Base also can be many areas. Imagine the whole lung and the dip as well, the corner of the lung. All those areas on an average should come out to be 0.6 V over Q. Remember, Q is more, V is less compared to each other in the basal regions. And as you go up, V over Q starts to rise up because V is increasing or V is not increasing. V is decreasing lesser than Q. Q is really plummeting, dropping like anything. So the ratio starts to increase. This point here can cause confusion when you are on your own study, that things are decreasing, both are decreasing as you go from base to apex. Then why does V over Q increase as a ratio as you go from base to apex? It's mathematics. So I just wanted to say it just one more time that V over Q is lowest in the lower areas of the lung, highest as you go up. Please remember that. This is a nice diagram to show you. We start the graph at the base, we go to the apex, perfusion drops, ventilation also drops, but look at the difference. Perfusion really drops as compared to ventilation. And when you calculate the V over Q, it rises. It is a graphical representation of what I just said. Now comes the question. Now that you understand hydrostatic pressure creates zones in the lung, now that you understand that exactly how do V over Q differs between the top areas and the bottom areas and the middle areas, in the middle it should be around I said base and apex. What about the middle? What would the V over Q be in the middle? Near to 1, almost equal. Okay, as you go down, it should drop. As you go up, it should increase. For you to think about the following question. If blood is returning from the apical areas of the lung and compared to blood returning from the basal areas of the lung, could you comment or think about what would be the difference of the oxygen content of these two bloods? And then later on, once you have figured that out, think about the difference in carbon dioxide of these two bloods. It really encompasses everything and a bit more. It stretches your imagination. So think about lung zones, think about the pressures, think about V over Q. So what is happening? In the higher areas, it's less blood, more air. Yes? In the base areas, there is more blood, less gas. The blood that comes out of the apical areas, however less it will be high in oxygen as compared to the lots of blood that you get from the base of the lung. What about carbon dioxide? Carbon dioxide content of the blood that is coming from the apex should be lesser than carbon dioxide content of the base of the lung. And I will just say it in one sentence which should clarify anything which is left. It's if you can just think of a warehouse, In this warehouse, there are people who are handing out packets. Number of packets given out is the output of this warehouse. So a warehouse one is handing over packets, whatever, to less number of people. So if you are at warehouse one, you have more chance of getting a packet or maybe more packets because there are just fewer people and lots of boxes as compared to warehouse 2 where there are a lot of people and lesser boxes. So converting it into lung terms, very less blood, lots of air. So it has all the time to soak up more oxygen and give out more carbon dioxide because the air is just too much and the flow is just too less. While in the lower areas, there is rush in a mall near Eid. Okay, too many people, too much blood, and this blood, not all the blood has time to equilibrate with the alveolar air. So it cannot soak up oxygen properly, and hence it can't give out its carbon dioxide properly either. Hence this blood, quality wise, blood gas wise, is average, while the top region blood is literally too good. Okay, both are not good. The middle part is the best, where V over Q is equal. So whatever blood is coming, it's getting a nice treatment of oxygen and proper removal of carbon dioxide. Yes, in normal individual, these changes in the apical and base regions average out nicely. There is not a huge conundrum in blood gases. You get 95 mmHg in arterial blood, PO2, and 40 mmHg carbon dioxide in arterial blood. This is your average blood gases with slight variation in a normal human being, and everything is fine. Now let's come to the clinical bit here. This is the clinical bit. Mycobacterium tuberculosis. What is this? This is the organism which causes tuberculosis, TB. Guess where it thrives? Apex. Why? What is in the apex which it really likes? High oxygen content, air with high oxygen. This is where it thrives. Less flow so that it cannot be swept away, but very high oxygen. So in a TB patient on an X-ray, always start looking, if you're suspecting TB, start looking from upper areas. And most probably you will find a problem, an area of tuberculosis in the apical regions of this lung. This is now, we are going towards its practical implications. So V over Q does not, it's just a ratio. It can be off-throwing. It can be seriously off-throwing if you are only looking at the ratio. So the point here is, the message here is, V over Q should be read along with the rest of the patient's data. Always go for history, always go for physical examination, always go for looking at the X-ray, CT or MRI, then look at, along with this whole picture, then look at the VQ. Because if you only look at the VQ, it can be misleading. What happens in lobar pneumonia? Pneumonia is basically messing up of lung tissue. It's not properly doing its function. Okay, it's not receiving air. It's just messed up. An area, a dysfunctional area of the lung, which is not being aerated. It's not receiving air because there is either fluid filled here or some other destruction has happened. Okay, we will look at it at the end of this series, what pneumonia is. So sometimes pneumonia is not, thankfully, it's not in the entire lung or even in one whole lung. It's localized in one lobe of the lung. Here, you would have a patch of pneumonia, for example, which will not be receiving air. Hypoxic, yes. Now, initially, calculate the V over Q. V would be down as compared to Q. Q will be up. So you will have decreased V over Q. Would you have decreased over V over Q or not? Because ventilation has gone down as compared to Q. However, something will happen in a day or two to the blood flow to this area. I taught it yesterday. G. Yes. Remember, lung pulmonary vasculature has an exception. It has 3-4 exceptions we spoke about yesterday. One very important exception is when it faces hypoxia, it vasoconstricts. Systemic circulation vasodilates when it faces hypoxia, not pulmonary circulation. In pulmonary circulation, wherever there is a patch of hypoxia, the vessels in that region go into vasoconstriction. Why? We said why yesterday. What's the point of giving blood over here when there is no air? So it's actually a protective mechanism to divert blood to more fruitful areas. Yes? But check out what happens in lobar pneumonia then. You have dropped V and eventually you have dropped Q as well, resulting in a normal V over Q. And what horror is there that it's not at all normal. Both are actually decreased, but they are equally decreased. See how V over Q can be misleading when taken out of context. So it's a concept, bete. It's not a physical thing. You just make it up. You look at the ventilation, you look at the blood flow, which are physical events, but V over Q in itself is just a mathematical expression of two physical events. This is where the special recipe becomes or more special. Okay. I want to introduce to you what really in real life happens and can happen to a lung from the point of view of V over Q. V over Q here and V over Q here. So the lowest V over Q, lower V over Q, very low V over Q, normal or equal V over Q, higher, more higher, quite high, uncomfortably high, infinity. This whole thing. This is actually what happens. Guyton doesn't describe it. And when he describes the lower and highest end of VQ abnormality, people get confused. Where did this come from? Well, it came from this whole timeline. It came from these grades of V over Q from the lowest dump to the highest V over Q possible. Let's put this scale on the lung. Upright individual, base of the lung, apex of the lung. We are putting the scale right here. Let's make a scale. In the lower areas, V over Q is less or more? Less. So you would say base of the lung is low VQ areas. Can we say that? Now we travel up. We come to the middle-ish portions. We say it equals. V over Q is equal here. Now we go from the middle areas to the higher areas and it starts to increase or increase. So we say that we have come from the lower VQ to the normal VQ. Now it's increasing. So we say higher VQ areas. Yes? If you've understood that, you will really like this diagram. Start from the base. This is the base. So lower VQ areas, the lowest part of the low VQ areas is called a shunt, where the whole thing becomes literally zero. It shouldn't happen, or it happens very slightly, maybe, probably. So lower areas of the lung are here somewhere. They should be labeled as low VQ areas. Then you should have high VQ areas, and there are high VQ areas. We know this now. But what is the highest point, the abnormal highest point of high VQ areas? We call it, we have a name for it, dead space. The perceptive student will immediately label it as lung zone 1. Lung zone 1 is also called physiological dead space. The studious student would link it with the anatomical dead space now. When we mentioned that anatomical dead space is constant 150 ml, however, anything more than 150 ml in a person, that bit is physiological dead space. Now you know what physiological dead space actually is. It's an area of zone 1 situation where you only have air, you have no blood. Hence V over Q approaches infinity, and it should not happen in a normal human being. However, what Guyton does not, it skips this whole thing in between, is that it's okay to have high VQ areas, because this is nature, this is the effect of gravity. As you go up the lung, you will have a distortion of V over Q, and these areas will have higher VQ areas. However, it should not approach infinity. I've said it now. And the basal areas are, it's okay to have lower VQ areas, but it should not approach zero. When it does, we have a name for it. So now you know what's the continuum of V over Q. You have high VQ, lower VQ, and the middle areas. And then you have the abnormal stuff on this end called dead space, physiological dead space. And at this end, it's called physiological shunt. So shunted blood is poorly oxygenated. Blood coming out of low VQ areas are poorly oxygenated, high in carbon dioxide, bad blood, right? Blood coming out of higher VQ areas, more than usual oxygen, more than usual drop in carbon dioxide. What's the middle? The middle is you should have 104 oxygen, 104 mmHg oxygen, and 40 mmHg carbon dioxide. This is what is the ideal. Why? Because alveolar O2 is 104. And when blood comes, we will study this in next chapter. When blood comes, there is equilibration between alveolar air and the blood oxygen. 104, immediately this becomes 104. And that's the optimal. However, in higher VQ areas, it becomes more than 104, and so on and so forth.